Hello everyone. It's our pleasure to have you today in our first webinar in our webinar series of Africa. Actually, it's one of my very special, close to my heart webinars, since we're talking about our pioneers in Africa. And I'm from Egypt, I'm from Africa as well. So it's very, very special. And it's very special as well that we are starting with one of the very well-known and great professor, Dr. Linda. So thank you so much for accepting our invitation.
Thank you.
And I'm really sure that we'll be having a very interesting webinar. So I wanted to welcome our participants as well. Thank you so much for joining our webinar today, and I hope you will enjoy. So I forgot to mention or to introduce myself. So I'm IADS Vice President of Science and Research, and I wanted to give the opportunity for Dr. Noura Bouchaydi. She's our Regional Ambassador of Africa, because this webinar series, it wouldn't happen without the help of our Regional Ambassador of Africa. So hi, Dr. Noor.
Hello, everyone. Thank you so much for this heart-warming introduction. I'm very proud of the SCORE team and Dr. Mariam, Dr. Mahinor, and Dr. Itek for their hard work in organizing all of this. I'm very happy to have Dr. Linda with us here in this webinar. I've heard a lot about you, and there's many recommendations. Whenever I ask anyone from Nigeria, they say your name. So we're very glad to have you here, and it's a pleasure. I give the floor to Mahinor, Dr. Mahinor Godollo.
So thank you so much, Noor. And I would like to give the floor for our SCORE committee team, Dr. Mahinor and Dr. Ibak, our IADS webinar coordinator and co-coordinator. They were the reason behind all the effort that was implemented in this webinar series. So thank you so much, guys. And it's my time to stop talking, and you guys, it's your stage, and please moderate the session.
Thank you, Dr. Mariam. Honestly, it's amazing. It's a great opportunity to start off this term with this amazing SCORE committee and having you as our head, as our VP. So honestly, it's amazing. And working with Dr. Noor has been exceptional, to be honest. And Ipek, my friend, my colleague, and honestly, this would have come to life without your help, without everything, without all the constant texting. And of course, Professor Dr. Linda, to start off with you, to have you with us, and always just there to answer our texts, our meetings, and preparing everything. Honestly, one of the best professors and doctors to talk to engage with. And I'm so happy and excited to look forward to this session. I would love to introduce you as an pioneer and excel professor and head of restorative dentistry department, the Faculty of Dentistry in the University of Nigeria, an honorary consultant in the University of Nigeria Teaching Hospital, and over 20 years of experience in training and mentoring dental students. So just a brief introduction of what you are and who you are, honestly, doctor. So our title today for the lecture that's going to be by the Professor Dr. Linda is going to be about endodontic treatment in the developing world, the past, the present, and the future. I'll give the floor to my colleague and friend, Dr. Peck, and we'll go on from there.
Hello, everyone. Thank you all for saving time to join us this Saturday. We are proudly introducing our webinars for this term as the IADS Core Committee, and starting from the region Africa with the valuable Professor Linda Okoye. Thank you so much for joining us today and saving your time to educate us young dentists, and we are really happy and pleased to have you with us today. And I would like to, of course, give huge credits to Mariam, Noor, Mahinor, and all the amazing team behind this organization, and for their huge efforts for this month to happen and come to life. And now I would like to give the floor to the Professor Linda to start this amazing webinar. And thank you again for your efforts and time.
Thank you. Thank you.
Dr. Linda, I would request, please, if you could do it on a full screen, so can everyone would see it up close, please.
Okay. Right now,
Perfect.
I'm sharing the screen. Okay. Are you okay with the screen wherever you are?
It's not on presentation full screen. Is it possible if you could put it on presentation mode?
On presentation mode, back. Let's go back. And then okay, let's share the screen again or something. Is it okay now? It's hanging somewhere. I think, is it a network problem?
Um,
Oh.
No, doctor, you can find the full screen mode. It's on the lower part.
Is it
On
better
the
now?
right. No.
it's on the lower right, lower right bottom next to the percentage of the zoom in. It's the one right before it, the button right before it.
Do it. It's actually hanging. Yeah. Resume share. Okay, could this be? Is it okay now? What's happening? The screen sharing is paused. Why? I am saying resume. I think the host, please try and do something. It was paused at some point. Could you just enable me to share? It was paused from somewhere.
Doctor, no, we can see the screen, but it's not full screen. If you would like to return back.
Is it moving? Is it
No.
moving? No, it's static. I'm moving it and it's not even moving. It has been off somewhere. Okay, can we just start all over?
Yeah, we can start. No
Let's start.
worries.
New share. Yeah.
Yeah.
I want to go with new share. Let's see how it goes.
Yes, it's now
It's
working.
perfect now.
Yeah.
Yes.
So actually,
It's
needed. Okay. Let's see if it's just gonna move. Is it moving?
Yes, your cursor is moving.
Cursor is moving. No.
Now we can see the second slide.
No. A closed caption is being generated.
Yes, it's now working, Doctor. We can proceed.
Okay. So we can actually start. I'm sorry about this. This is like first experience in a very long while. Okay. Now let's go. I want to first of all congratulate the SCORE members, the members of International Association of Dental Students and the Standing Committee on Research and Training. Today I want to look at the topic endodontic treatment in the developing world. And we want to look at the past, the present, and what the future holds. Here we go. We will consider this under the following introduction, rationale for endodontic treatment. We look at the basic anatomy, for root canal system. Then we'll look at the past, the present, and the future of the different stages of endodontics. Then we shall conclude and then do some interactive sections. I will try to rush it so that we'll have enough time to interact. With the development of new technologies, new concepts, new techniques, and instruments in the field of endodontics, okay, you find out that pulp cleaning, shaping, and obturation of infected root canals in the past few decades has gained a new outlook. Unfortunately, the advancement is grossly less appreciated in the developing world, okay? And it's all right. Nevertheless, before delving into our challenges, we need to first understand where we are and learn from where we have come from with the future in view, knowing that today's best is tomorrow's building block. Okay? So the past what's happening? The past, the present, and the future actually encompass concepts that are logically and physiologically intertwined in the sense that the existence of the future is because there is a past. And the present only serves as a bridge pointing to the possibility of the future. So this is true based on the fact that despite the load of advances witnessed in endodontics over past years, the basic fundamental principles of endodontics is still preserved. So the basic is so important in whatever we do. Many things will be evolving, but the basic can never be left out. There are two basic principles observed in endodontics. One, remove the irritant, be it chemical, bacteria, or mechanical. Two, seal the canal hermetically. If there is no hermetic seal, the root canal therapy will not be a success because there will still be communication. So these principles remain sacrosanct in the practice of endodontics, regardless of the location, even if it's in the Western world, in the village, or in any part of Africa, and all the time. Whether it was done in the 19th century, the 20th century, 21st century, the principles, they actually remain sacrosanct. From the use of human applied instruments and technologies to the incorporation of artificial intelligence in endodontic treatment, it is evident that there exist considerable steps towards the future. So that future is not just transiting from past to present to future. A lot of things, a lot of steps, a lot of findings, a lot of discoveries have come on board, and many more are still yet to show up because researches are ongoing to make sure that many more technologies are discovered. However, there are still uncertainties as to where the practice of endodontics in the developing world is meeting up with the advances. So the story of that of the developing world is really a bit different because challenges abound. So this uncertainty is not far-fetched as the developing world is plagued with challenges hindering the awareness, acceptance, and utilization of some basic to advanced endodontic procedures. A lot of people in the developing world do not even believe that what you want to do for them is for their own good. They have not accepted. Some are not aware. So it's a problem, and it puts the barrier, a huge, long one. So some of the challenges actually include poor utilization of oral health care, poor awareness of endodontic treatment among the populace, Then limited access to dental care due to poor dentist to patient ratio, limited power supply, debilitated infrastructure. That notwithstanding, compared to what was obtainable some decades ago, it can be inferred that efforts are relentlessly being made to overcome these challenges, both in the teaching and practice of endodontics in the developing world. So while we look forward to a bright future, let's cast light on the past, the present, and the advancement in every step of endodontic procedure. We will be looking at, our focus is in the future, but we'll look at what it used to be and what is in the now, what it is. So generally, endodontic treatment is done to preserve tooth, retain the tooth in the mouth, to maintain aesthetics, preserve function, example, masticatory functions, prevent infection and its spread, prevent speech problems, and prevent bone resorption. The indications for endodontic treatment include, but not limited to, irreversible pulpitis, tooth fracture involving the pulp, that's Ellis class 3 fracture, then the heterogenic exposure, apical periodontitis, pulp necrosis, that's the death of the pulp. When the pulp is already dead, what's more? Get in and take out the necrotic tissues and let the tooth remain in place. Preparation for post-anchor, where this tooth may be needed as part of a bridge work. There are contraindications for endodontic treatment, and it ranges from patient's attitude, incooperative and non-compliant patients that do not comply with appointments. They wouldn't be good candidates for endodontic treatment. Poor oral hygiene. People with very poor oral hygiene, there is no way that they will have success when you begin endodontic treatment for them. Then inadequate assets. Sometimes the mouth you cannot open very well, maybe 2-finger breadth or 2.5-finger breadth, and then the tooth is located posteriorly. Insufficient periodontal support, as example is grade 3 mobility. When the tooth is moving in all the direction, up and down, sideways, why would you bother yourself when there is root resorption that the hermetic seal becomes difficult? In cases of root fracture, and then in cases of bizarre anatomy, especially with our third molars, especially the upper third molars. So for successful root canal therapy, the anatomy and the morphology of the tooth is very important and should be considered. Vis-a-vis the root outlines, the root canal length, the number of roots, the number of canal space tooth, the longitudinal and cross-sectional shape, the root canal configuration. You can see a morphology, a cross-section of a tooth. Okay, this is just to show us, I'll just rush over it. It's a picture lifted to show the length, the number of roots, and the number of canals of various teeth, all the teeth in the mouth. If you want to practice endodontics, want to do a successful endodontic treatment, you must acquaint yourself and grab the detailed knowledge of the anatomy and the morphology of the tooth. Oftentimes, they have said that this is a blind procedure, but when you have the information and then you have other facilities and technologies that will help you to see beyond what is in the mouth, then it will no longer be considered as blind. Now, you can see that in the canal itself, the canals are configured in different ways. What is happening in a particular tooth in an individual's mouth will not be exactly what you will see in that same tooth in another mouth. When did a classification, and it came up with a 4, whereby you have a single root that starts as single, ends as single. Some start as a single, bifurcates into 2, and ends at single. Then some start as single and bifurcate, and then some will start as single and then end up at as a 2. So you find out that if you are not aware, the proper cleaning, shaping, and obturation of this canal will be an issue. Then even when some vertices root canal configuration system, you can actually see sorry. You can actually see that that will affect your treatment if you're not fully aware of what it should be. Let's quickly go to, okay. Let's go to the first stage, the medical and the dental history, where you ask for the biodata, presenting complaint, history of presenting complaint, the past medical history, the drug history, family history, social history, and the systemic review. Okay, this will definitely help you to make a proper diagnosis and make a good treatment plan. After you have gotten this whole history, diagnosis will result from defining the pathological condition of the pulp and the periapical tissue following the detailed history, clinical examination, investigations, that is your radiograph and special tests, treatment planning draws conclusions on which tooth or teeth to be treated. So the approach and the sequence of management will be the next. In clinical examination, traditionally, your dental mirror and probe are used in gross examination in the oral cavity. There are advancements, but I tell you something, an understanding and proper use of your mirror and probe will even put you in a position where you can compete with the new technologies. Why? Because this is an age-long examination instrument that has stood the test of time. It has done a lot. Why newer modalities exist for clinical examination? It is important to note that the dental mirror and probe are not primitive and still serve as an important examination device. There are other special tests that are done, like the bite test, the tooth sleuth, selective anesthesia when you do intraligamental injection, when pulp testing is inconclusive, okay? Then you can go ahead with your pulp testing. The pulp testing, you can do thermal or cold, and you can use electric pulp test, laser Doppler fluorimetry, or pulse oximetry, any of them, for example, that, okay? Special tests continues, like your frac finder that is used to find out the fracture and the rest. Then staining and trans illumination, where you have a bright fiber optic light, and then it's actually the light probe is used to find out what exactly the problem is, where there are dark areas and all that. The crown surface temperature, you're looking at the future. When you talk about the frac finder, the fiber optic light probe, some people are already using the stain and trans illumination bright fiber optic light probe, but in some places, I say whatever that is not used in your center, in your clinic, it is not in your present, then that should be counted as part of your future. You're moving towards that. Trans-illuminated light photoplatismograph, then the xenon 133 radioisotopes, dual wavelength spectrophotometry. So this can be used as special tests in diagnosis and then planning of your treatment. In the past, dental fluoroscopy had been used. Then in the present, as we speak now, we have the fundamental radiograph, and then the periapical radiograph, the OPG, orthopantomogram, the cone beam computerized tomography. CBCT is used in some places already, and then in some places, they haven't experienced that, so it's still in their own future. All caries and defective restoration should be removed when you want to do a root canal therapy that will be successful. You need to prepare. the tooth before isolation. If necessary, the tooth should be protected from fracture during treatment. So the tooth form should be restored to facilitate isolation. If you're using your rubber dam for isolation and the tooth is fractured, the crown is half gone, how would you isolate? It will be an issue. The periodontal status should also be sound and or capable of resolution. Now, we're looking at the isolation. In the past, cotton roll and gauze have been used in the past. I want you to know that even in the present, they are still being used. Look at those two cotton rolls with the cotton roll holders, and then that there, okay? So they are used in the past, and they still pass for the present. Saliva ejector is common everywhere. Rubber dam is actually the gold standard. It gives you what you want, okay? In the future, the use of isolite system is what the future holds. This is a novel isolation system recently introduced in dentistry. It's for our own future. So the system requires specific armamentarium to set it up. However, it's very compressive. And it comprises of, you have the high volume evacuation, there is a biting block where patient bites on, protective barriers that will now keep away the tongues and other soft tissue. And it has a lightning point, retraction apparatus too. So this is it, and that is what is in the future. It's being used already in some places, but for us, we are getting there. It's in our future. In visualization, we talked about the dental mirror, the all ever faithful dental mirror with which you can see. I always tell them that the stethoscope of a medical doctor, your mirror and your probe is like the stethoscope, okay? Everything you want to examine in the mouth, the mirror comes in handy first before any other. So the visible light on the dental chair, then you have your dental loops that will magnify some things, and your endoscopes that you can use. Then the future, you have the horoscopes for us, operating microscopes. Now the microscopes are already being used in some places, but a lot of places in the developing world, they are yet to commence. So it is in their future, okay? So right now, let's see. The access cavity is actually the first step. What is the objective? To remove the entire roof of the pulp chamber so that the pulp chamber can be cleaned. If the entire roof is not removed, you may not be able to locate all the canals. To enable the root canals to be located and instrumented by providing direct straight line access. Okay, it has to be direct because the reamers and the files will not be bending back and forth. The initial access of the cavity may be modified to achieve this. To enable a temporary seal to be placed. That is a picture of trying to make access cavity for this molar tooth. To conserve as much tooth tissue as possible that is compatible with what we have mentioned already. So prior to the preparation of the access cavity, the radiograph should be studied to show the size, the shape, and the position of the pulp chamber. That will guide you when you are making your access cavity. If not, you are likely going to miss out some canals. Or for the amateurs, the students who are just coming on board, some keep looking for the canal orifice until they get to bifurcation, and then they eventually destroy the tooth. Most of the access cavities can be prepared with high-speed drills. The final stage perforation of the roof and its removal from the pulp chamber should be done at a slow speed. It has to be. If not, you may have other problems in your hand. So this is like a list of armamentarium that can be used in access cavity preparation. You have the balls, different types of balls, the round ball. First of all, the fissure ball, you get it to the shape you want, and then the round balls, and you now get it there. And when you locate the canal, you have to also make it straight and then prepare it open enough for the use of the instrument. So the round balls, the straight fissure ball, the rose head balls, the safe-ended diamond ball, and your gate gliding ball. It has 1 to 6 sizes. Gates grading board for some people is in the future. They are not using it yet. It's in their future, but it is part of it. I'm showing you the two pictures, lifted, maxillary arch, mandibular arch, showing the shape of the access cavity of every tooth in the mouth. This is actually determined by the position and the number of the canals. You have to know this if you want your endodontic treatment to be successful. What is the objective of working length determination? After the access cavity, the next thing you do the purple extirpation, then the next thing I want to talk about is working length. To enable the root canal to be prepared to the apical constriction, that is the narrowest aspect, approximately 1 to 1.5 millimeter from the radiographic apex. Then you are determining the working length so that you can confine the root canal instruments and feeding materials within the root canal. For a successful RCT, a basic knowledge of the approximate root length of the various tooth is very necessary. If you know it, then you now know what to do. How do you determine the working length? There are methods. In the past, you could say, there are the non-radiographic methods, digital or tactile sensation, apical periodontal sensitivity, even the use of paper point method. They have used all that in the past. Now, even the Grossman's formula, the Ingalls method, and the Wentz method have been used in the past and is still used in the present. Okay? So you can see some if you're going to be using your tactile, you can later confirm using your apex locator, and then you use your apical periodontal sensitivity, then all these methods could be used. In the present, I say we still use all these methods, the Ingalls, the Wayne, and the Grossman. Yes, it's still practiced. Then we also use electronic apex locator. Then some combine the apex locator and the endo picture, okay? So you find out that the apex locator can function by itself, and sometimes they combine the function of the two. So apex locator is actually the most advanced and the fastest growing method of measuring working length without the use of radiography. So it has become a must-have device in endodontic practice. The apex locator, as the name suggests, dictates the apical foramen, the cemento-dentinal junction, or the apical constriction. So that's the apex locator. You have a part that is etched, either you put on the lip or the patient holds it in the hand. And once it gets to the apical constriction, there is a deflection. And then you can actually combine apex locator and endodontic handpiece. In this case, the endodontic handpiece is attached to one end, of course, to deliver it into the canal. So it reverses the rotation of the instrument when it reaches a point in the apical region preset by the clinician. So apex locators can only reliably determine when the file is touching the periodontal ligaments at the apex. You set your working length 1 to 1.5 millimeter back from the length to avoid over-instrumentation. Well, you should know why, because the anatomical apex and the physiological apex are not exactly the same. That's 1 to 1.5 millimeter. It's very important. So for our future, there are methods, the audiometric method, the zero radiography method, the direct digital method. For our audiometric method, you're just using a 2 points to find out what the length should be. So you can introduce the instrument right in the gingiva, and then until there is a sound produced. And then you move again into the canal, and then the sound is produced. Then you compare from this to this. It gives you an idea of what the length is. In zero radiography, it means that the radiography, the rate is 0. And then you have your what do you call it? The intraoral sensors that you can use to just get your direct digital radiograph. You just put it where you want and you see it showing on your screen. I mean, I find that very, very handy and even simple to use. So this is the future for some people. While others are already in it. They are using them already. Okay. So we want to talk about the biomechanical preparation. Biomechanical preparation. What is the objective? The removal of all organic debris from the root canal is very important. Anything left behind can multiply and give you another result. The elimination of bacteria from the root canal and the shaping of the root canal to receive a filling material that will obturate the root canal system. That is exactly what happens in the biomechanical preparation. Now, this armamentarium have been used. You have your files, your remarks and your files, your endodontic K files, remarks. Then you have the reciprocating handpiece, the rotary endodontics, that's the modern device. The remarks and the files have been there. Over the years, it has been used and it has given us the beautiful result ever that we desired. So you can actually say, like you can see some files here, they are engine-driven files when you have rotary endodontics. And then you see your handheld files and remarks. They have been the old faithful. And then you can see your reciprocating handpiece that is used, your rotary endodontic, which is what is in vogue. And of course, it's still in the future of some people. So in the past, manual use of remarks and files, was okay. It sufficed for us, and we use it to get all the beautiful results that we desired. Then, of course, sorry, that was in the past. Then in the present and in the future, these other ones, the engine-driven remarks and files, the reciprocating handpiece, the rotary endodontics for cleaning and for shaping. But I tell you something, proper use, skill acquisition, and making sure you remove all the contents, the irritants, and then the necrotic tissues, and shaping the canal to receive the obturating material is highly very important. Okay, we'll talk about the techniques of root canal preparation. When you talk about root canal preparations, a lot of techniques have been used. Apical to coronal to apical, conventional setback, modified setback, passive setback. The list is like unending. But initially, what we used to do was that step back, step down, preparing from the apical, then to the coronal. But recently, you see, it's now from the crown down to the apex, okay? And now there is a hybrid double-flared balance force technique. All right, you find out that the manual methods are there, the actions are there. And for the students, begin where you should begin. Some people want to jump into the engine-driven, the use of machines when they have not tried even the manual. It's good. Start with the manual. Then you can appreciate what you're doing with that. So the filing motion, the push and the pull, the reaming motions, the watch winding, the balance force technique, your files and your remarks, this is what they do. If you're reaming quarter to half turn, then pull and then insert again, quarter to half turn and then pull. That's how you keep enlarging the canal. Now, in the present, mechanical methods that are used in the present, the use of engine-driven instrument and instrument motion, that's reciprocating handpiece and endolift. Then the use of night-tie instruments, even though it could be hand-driven, it could be rotary, but the instruments are now made of a different material. which has memory and can actually retain the whatever even after the curvature. Now, you find that they're already available and widely used. Then the high elasticity in rotation, you have the reamer with alternating cutting edges, the self-adjusting file, and the appraisal device. Appraisal device is in the future of a lot of people who are not yet using that. Okay, in the present, mechanical methods used, development of different instrument designs to overcome the disadvantages of the current rotary instrument, then combination of both the idea of the torque control motors and then the EPS locators so that the clinician can have a live reading of the length during preparation procedures. And even when patient is recalled, whatever the reading is, it's still in the system for it. Let's quickly look at irrigation. What's the objective? To lubricate your root canal instruments to avoid fracture. And remember, in the past, stainless steel, if you don't do copious irrigation, you will definitely have fracture in your hand. The solution of organic debris, and then flushing of micro organism, bleaching of the tooth to prevent staining. These are some of the examples: normal saline, lidocaine solution, sodium hypochlorite, and the EDTA solution. They have all been used. So in the past, hydrogen peroxide, iodine, potassium iodide, chlorhexidine, phobocresol, because of their activity in antimicrobial activity against the bacteria. But phobocresol, to be specific, was implicated for its toxicity. So in the present, sodium hypochlorite dilute is still used, and then your EDTA solution is still in use. The triple antibiotic paste, combining the ciprofloxacin, metronidazole, and your minocycline, okay? Then the ledamis is another thing that is also in use. For some people, they are yet to start using it. They hear of it, they are yet to start using it. It's just a mixture of triamcinolone and D-meclocycline. Calcium hydroxide is the old faithful, the non-setting calcium hydroxide. It's used in intracanal inter-appointment as an antimicrobial agent. In the future, we're looking at ultrasound-activated irrigation. That is the future. Ultrasonic devices are increasingly being used in endodontics. So future irrigation methods may involve ultrasound-activated irrigants, where the mechanical vibration generated by the ultrasonic tips enhance the distribution and effectiveness of the irrigating solution within the root canal cell. So everything there, it will just irrigate everything, flush out what needs to be flushed out. The photo-induced the photoacoustic streaming, that's the PIPS. So this PIPS is a laser-activated irrigation technique. It utilizes laser energy to generate the photoacoustic waves. So the approach may improve the penetration of irrigants into complex anatomical structures, enhancing the overall cleaning and disinfection of the system. So this is the future. Also, our endo activator is for the future, and endovac is for the future. It's used for proper cleaning of the canal. The safety irrigator is also for the future. I said earlier, all these technologies, in any system, in any institution, in any clinic where they are not yet being used, they are focusing, they're going there, is their future. Anybody who is using it already is in his own present. It is never in the past because it is still very useful. All these things, they have their numerous advantages and disadvantages. There is no one that you will say, oh, this is the best and does not have any shortfall. They have their shortfalls and setbacks, but when the advantages outweigh one or two setbacks, of course, we find them so useful. Now we want to look at the medicaments that have been used in the past. Aqueous parachlorophenol, quercetin, they have been used in the past. They have not been continued because they have been implicated for their toxicity too. And then in the present, calcium hydroxide has remained. Then our TAP, triple antibiotic-based lead-amide, the future endodontic medicaments, is likely to see the advancement aimed at improving efficacy, safety, and precision in the root canal treatment. Why predicting specific technologies is challenging, several trends and potential developments are expected in the coming years. People are working hard to actually come up with a lot of newer things that will really help to clean the canals faster, better, and without much toxicity. Let us look at the obturation of the canal. After you have cleaned everything, you will need to obturate. That is it. These are the materials that can be used. Your paper points to dry, your gutta percha, you have your lenturospiral instrument to put your the sealant, you have your spreader when you're doing a multiple points, and these are the different sizes of the gutta percha. Okay. The development of hermetic seal of the apical foramen and accessory canals prevents any communication between the root canal system and the periodontal tissues. And this is very important and an ultimate goal in obturation. If after obturation, the lateral canals, the apical deltas, there are still loose areas, there could still be communication, then you are running a risk because success may be far from what you have just performed. When do you obturate? After root canal cleaning and shaping. When the tooth is symptomless, no pain, no swelling, no no symptoms. The canal is dry or can be dried with paper points. Patient may come in and the canal is not dry, but you can dry it with the paper points, then you can obturate. This is a picture of a beautiful obturation. What I love about that picture, the x-ray there, is that all the canals, even the bent ones, the curved ones, everything well obturated, thickly, and there is no place that is left unobturated. Okay, talking about obturation, in the past, we had used the orange wood stick in the past. We had also used the precious metals such as gold, the bronze, the dental cement, just ordinary cement to obturate. People have used amalgam and silver points. I remember silver points that were used in those days, and then you have to cut it somehow and you have to do a sectional filling and all that. But now, no more. Gutta percha, when it came on board, we saw that it gave us all we desired, more or less, okay? And it has been there. It's in our present. And I'm sure even in the future, the gutta percha is still there. But diverse ways, different methods. The Lexilon is in the future. The gutta core obturator is in the future, okay? Talking about the endodontic sealers, we have the zinc oxide eugenol sealers, the calcium hydroxide sealers, the glass ionomer sealers, the resin sealers, the bioceramic sealers. Over the years, zinc oxide and eugenol, or the derivatives of zinc oxide and eugenol, the calcium hydroxide, the GI sealers have been used currently. The glass ionomer sealers, the resin sealers, and the bioceramic for some people. Why for some others? They are yet to get onto that, okay? So the silicone sealers, the metaacrylic, and the resin-based sealers. Sorry. Talking about the obturation techniques. different techniques have been used. The cold lateral compassion, the warm lateral compassion, the warm vertical compassion, the continuous wave compassion, the thermoplasticized gutter pressure injection, the carrier-based gutter pressure, the thermofill. The thermofill, thermoplasticized technique, chemically plasticized gutter pressure, then the simply fill sectional obturation, the max padding thermomechanical compassion, then the custom cone obturation. These are the techniques that can be used. Initially, we were comfortable just using the single cone. Single cone came in very handy. And then after the use of the single cone, we saw that there were shortfalls in the use of the single cone. So the single cone, currently, many people want to actually use the multiple points. You use the main point, and then you're going to use the smaller gutter patches to make sure that no void is left. It could be cold, it could be warm, and then that's the way it goes. For some people, the continuous wave compaction, as well as the simply fill sectional obturation, the max padding, and the custom cone are in their future because they haven't gotten there yet. But that is the option. These are the things that are done to make sure that you obturate the canals. And having said that, I want to conclude this afternoon by saying that in addition to transformative technologies emerging in the practice of endodontics, vital advances in regenerative endodontics, stem cell mediated regeneration, and repair of damaged pulp dentin, as well as integration of artificial intelligence are the prospects. That is where we are going to. Why the transformation might not be very significant or diffuse in developing countries, there is still need for a continued effort towards the actualization of this feature. Nevertheless, endodontic treatments in the developing world are advancing with a leap from historical and traditional approaches to embracing modern technologies. So the future is bright, with ongoing and continuous initiatives to enhance education and improve infrastructure and manpower. Certain modifiable challenges facing the practice will be arrested. It is important, therefore, for policymakers, executives, and public health organizations to collaborate in addressing these challenges and advancing endodontics in the developing world. These are my references. I wish to acknowledge the people, my team. I am not alone. I work as a team. Some of my students are part of this. First of all, can I appreciate the SCORE team that has put this thing together. You have worked tirelessly to make sure this goes on. I commend you because with this, there will be improvement, sensitization, and education of upcoming dental surgeons. And there will be collaboration and even comparison across board on what exactly ought to be. So I also want to appreciate my team members, people in my unit, Dr. Wamba, Dr. Felix Ebonwono, Dr. Obi, Dr. Basi, Dr. Iwoha, Professor Udoye is in my team. And then we have put heads together to make sure that endodontic practice in our center does not lag behind. And we also look forward to the future. That is why, as we talk about the past, we look at the present, and our focus is in the future. What we have now is just a bridge. Thank you so much for listening, and I am open for any question. God bless you.
Thank you very, very, very much, Professor Dr. Linda. Honestly, this lecture was amazing. It's like you took everything that we learned in 5 years in endodontics, you showed it up, you gave it a wrap up, and you added in your own twists and your own advancements. And you've always showed us you've also showed us what the future holds in just snippets and quite simple and concise and to the point that I was there all the time, and I'm pretty sure all of our participants have really enjoyed this too. I did, and I'm really, really, really looking forward to hear from you more and to do this again and to see the future come into reality with you and your beautiful team. So I would love to also thank your beautiful team for their help in society in general and in dentistry specific. So thank you again on behalf of everyone here, behalf of the SCORE team, behalf of IADS and the participants. We have a question for you, Doctor.
Okay.
So question is, which biomechanical preparation method would you recommend for a beginner dentist in 3rd or 4th grade? Is it okay to jump right in with using rotary instruments, or learning from manual filling methods is better? You're on mute, Doctor.
Thank you. I'd already said that in the lecture, that for students who are just beginning, please endeavor to start with the manual. Use your fingers, start with the manual instruments, then you can move to anything. There is nothing as beautiful as having the basics. It will help you to appreciate any advancement. So the manual, even for obvious reasons, a beginner is a beginner. You don't just jump into what you can control. You start with the basics, you acquire experience and skill, then you move on to the latest advances. It is allowed. That's my take on that.
Thank you very much, Professor. Thank you very, very much. So we have Ipek, you have your hands up, please.
I want to personally and on behalf of my team, thank you, Professor Linda, for this enlightening and summarizing yet really, really educating lecture. And I actually have a question myself as well. I would like to ask if what is your point of the bioceramic sealer usages, since they are getting very common nowadays, but because of their regenerative and hydroxyapatite inducing effects, since there are actually some recent studies about their possible calcifying effects on the root canals as well. Like, what is your idea of using and getting more common with using bioceramic sealers? Thank you.
If I got you right, you asked me what's my idea of using
since I said, because yeah, it really induces hydroxyapatite, but it is actually said in the recent literature that it might use calcification inside the canal as well. So what do you think about it? I am curious.
Well, for the biomechanical preparation, my own idea, I haven't used that, okay? In the literature where they have talked about it, they also mentioned the shortfall, the possible calcification. So I will want to say, anybody who wants to try with caution, okay? But there are other ones you can also use and you are fine, good to go.
Thank you.
Yeah.
Doctor, there is a participant that asking, can you please get the soft copy presentation? I don't, are you okay? Or would you?
Yeah, it's okay. It's okay by me. I can hand it over to you and you can share with the students.
Sure, of course, Doctor. Thank you very, very much. Thank you,
Also,
Professor, honestly.
You have recorded the lecture.
Yes,
And I
you did.
can
It's
be
recorded.
recorded so that they will also benefit from the recording.
It's on our YouTube channel, so everyone can go back to it and rewatch and learn again from your beautiful presentation. That's pretty much it, all the questions that we have so far, Professor. If there's anyone else that would like to ask another question. Nope. So our Dr. Mariam is just updating everyone that the recording will be uploaded on our SCORE YouTube channel in 3 days.
Okay, thank you
So
very much.
thank you so much, Dr. Linda. It has been a pleasure to have you. And I'm sure that it will not be our last webinar with you as well. So thank you so much, and it's very nice to have you.
Thank you. I commend what you're doing. I commend all your efforts. Please, ride on. You may be setting some people on the right footing by this kind of webinar. So, all the best.
Thank you so much, Dr. Linda, and we hope to see you again in many IADS events in the future. Thank you.
Thank you very much. Thank you, Dr. Linda. Thank you very much.
Thank you again for everything, Dr. Linda.
Thank you.
And thank you for our participants. And please, we're looking forward to see you again in our next webinar.
And please do not forget to fill in the feedback form in order to receive your certificate.
Yes, well, it's in the chat. Thank you again, Professor Linda. Thank you very, very much.
Thank you.
See you
Bye.
soon. Bye.
Mhm.